mornings where nothing went right. Woke up later than expected, and the wife's cat gets out of the house, and I'm chasing the cat for half an hour to the whole neighborhood. And I get here and I try to get some coffee. They're like, "We don't have any hot cups, but we can make this like really lukewarm for you." Like this. So it's just keep coming. It's that kind of day. Read that. Review from last time. Which of the following is true regarding anemia of chronic disease? Run the traps on it. Answer. Ooh, Lord. Ooh. Learning has taken place. I like it. All right. So we know it's a normocytic, normochromic process, so that takes one out. Ferritin is the storage. It's locked in, stays normal or elevated. Hepcidin is what? Yeah, you guys got this. All right, there it is. And that one. 6-year-old, healthy, brought into clinic. And mom brings her kid to you. G6PD deficiency concerns. What are you going to counsel this parent on? Also B. Right? So that kind of process is you just want to avoid the badness, avoid the triggers. And you have to know what the triggers are, right, in order to avoid them. You have to be able to counsel these patients. Hey, you might not want to do X, Y, or Z, right? All right, any questions on the stuff we covered last time, seriously? No? All right. So if you're following the lecture format, kind of like I mentioned on day one, we're going to skip around a little bit, right? Lecture 5 technically is like transfusion or whatever. We're going to kick that one to the back. So we're going to do the bleeding disorders and platelet disorders today. Hemostasis and bleeding. The usual, right? Your objectives. All right. You guys all remember the coagulation cascade? You got it memorized? Tattooed on the back of your hand, your eyelid someplace? You might want to if you don't already. All right, so let's go through this, all right? So, what's hemostasis? Blood clot, hemostasis. You want to keep blood where it belongs, inside the vasculature, right? So the body does what? And that's what we're going to talk about, this process of hemostasis, right? How do we maintain that? So primary, vascular spasm formed a platelet plug. Any of this familiar? Mm-hmm. All right, cool. I like it, easy. And secondary is what? So you got a fibrin matrix that forms to stabilize that platelet flow. And that's the part that involves the coagulation cascade. And then if the body's clotting, at some stage you got to reverse that, you got to stop that, and that's that fibrinolysis process. Okay? So primary, vascular spasm, platelet plug. Secondary is that fibrin matrix being formed. And just some good old-fashioned, right, where most of these coagulation factors synthesize the liver, and those are your vitamin K dependent factors. All refresher. So there it is, right? So you have an injury to a vessel. What does the blood vessel do? Spasm. It clamps down, right? Because in clamping down, you do two things. You make that diameter smaller, so less blood can go, but then you bring all the coagulation factors in contact with each other. Blood vessel damage, there you go. Exposes that subendothelial matrix and then starts that platelet activation, right? How about this? This familiar? No. Let's talk about this. So this is the platelet plug phase, right? So you have an injury to a vessel. The subendothelium exposes von Willebrand's factor. What happens is the platelets go by, binds to von Willebrand's factor. When that occurs, it activates these other sites on the platelets, and it transforms them so now they can bind to fibrinogen, which then binds to another platelet. And this process just continues and continues until you form that platelet plug. Right? Some endothelial layer exposed, your von Willebrand factor gets exposed, it binds to your platelets. Those platelets then, in the presence of ADP, which is released by the platelets, right, converts this binding site so that it can bind to fibrinogen, and just goes on and on. Any questions? Easy, right? That's your platelet plug. And just going back to this, right? So, and we don't need to get too knee deep into this, but inside the platelets, you have those alpha granules, right, and the dense granules. The alpha granule has von Willebrand factor and fibrinogen, so you're getting more fibrinogen there. The dense granules has serotonin and the ADP. What does serotonin do? What's the benefit of serotonin? That causes vasoconstriction. Then we form our platelet plug. Then we need to form the fibrin matrix, right? And this is where the coagulation cascade comes into play. Initiation, propagation, sure. Extrinsic and intrinsic factors need to be familiar with. Right. Yep. Both pathways, got it. So there it is. Right. So that's your coagulation cascade. Extrinsic, intrinsic, common pathway. What's the end result of the coagulation cascade? What are we trying to get to? Fibrin. Trying to find that fibrin to form that fibrin matrix. Right, that's the end result of your coagulation cascade. So you can see, right, this, go ahead and activates that, get to 10A, get to your thrombin, right, gets down to here, your fibrin clot. And that's the goal here. If you disrupt this anywhere in the process, you don't form that fibrin clot, right, and your ability to control that bleed is affected. All right. In a nutshell, injury to the vessel, vessel spasms, you form your platelet plug. In order to stabilize that platelet plug, your coagulation cascade kicks in and you form that fibrin. That's kind of what hemostasis in a nutshell. Everybody good? I feel like this is just review for you guys and I should just sit down and let one of you teach it. Who's up next? No? All right. Okay, so under the electron microscope, that's what it looks like. Right? Your platelets, and that's your fibrin matrix as a result of that coagulation cascade. All right. So again, clot, 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 clot. Somehow I have to turn this process off. Right? So antithrombin inhibits thrombin and 10A, sure. So this is your off switch, right? Your antithrombin, protein C, protein X. And we're going to talk about those specifically when we talk about the thrombophilians. Fibrinolytic system, again, the off switch. How do I reverse all those clots? At the end of the day, it's that plasminogen, right? Converts to plasmin, and that kind of breaks down your clots. D-dimer, what's a D-dimer? Yeah, it's that fibrin degradation product, and you'll see it in certain disease processes. There's a lab that you can order, so you can say, oh, what's been going on? There's been clot breakdown, and you'll see that with certain disease processes. All right, again, lab heavy course. PT, PTT, what is your PT measure? Intrinsic or extrinsic? Extrinsic pathway, right? Extrinsic, common, prolonging vitamin K deficiencies, liver, and I would say warfarin, right? PTT, your intrinsic, your common, and you can see the disease processes here where it tends to be elevated. Bleeding time, we don't do a whole lot anymore, right? But again, that will assess platelet function. Platelet, what's a normal platelet count? 150 to 450. Right. Fibrinogen levels and the D-dimer we talked about already. There it is. So prolonged, these are the disorders, those are the conditions you associate with a prolonged PT. And then obviously these are prolonged PTT. And we'll talk specifically about a bunch of these. Right? We'll talk about von Willebrand's and the hemophilias and antiphospholipids. All right. Yeah, just more of the same. Right. Good. All right. Disorders of primary hemostasis. So primary is what? Spasm and platelet flow. Right? Spasm and platelet flow. So that's what when you have that sort of disorder, you tend to see mucosal bleeding. Right? It's a platelet issue, typically. Right? You get petechiae. You get a prolonged bleeding type because something's wrong with the platelets. And we'll talk about von Willebrand's here in a little bit different. And then secondary is what? Secondary hemostasis. Fibrin, right? So that fibrin, you get the fibrin through your coagulation cascade. So there's something wrong somewhere with potentially one of the coagulation factors. And in that case, it manifests itself with these hemarthrosis, deep tissue bleeding, large hematomas. You can see that when we talk about the hemophilias. And then next is a both going on. No bueno, DIC. All right, approach. History and physical, no surprise there, like everything else we do. Start getting a good history, do a physical, and then maybe, so I gotta get some labs, right? So worried about bleeding issues, coagulation issues, you get your CBC, yes, and then your PTT. Fairly straightforward. Is the bleeding from more than one site? What does that suggest to you if it's like everywhere? Something systemic. All right, good. Is it lifelong or is it recent? You know, since they were a little kid they've been having this bleeding issue. Or is it something that just all of a sudden kicked in? All right. Again, are you thinking of platelet problem? Are you seeing mucosal bleeding, petechiae? Are they suffering from the hemarthrosis, which would suggest a coagulation problem? Yeah, good. And then there's petechial, right? There's little petechial rashes, petechial hemorrhages. What body part am I looking at? Knee, right? Hemarthrosis, right? So that knee is just full of blood right now. No bueno on that. All right. Von Willebrand's. Most common inherited bleeding disorder. Deficiency in the von Willebrand's factor. So go back to that initial opening with hemostasis. What was the job of von Willebrand's factor? All right, so the platelets bind to the von Willebrand, right, that activation. If I don't have von Willebrand's factor, you can start thinking what problem sets I'm going to have. All right, impaired platelet adhesion, right, and factor VIII stabilization. So that's the two things that von Willebrand does, right? Binds to the platelets, right? So it starts that platelet adhesion process, your platelet plug, but it also stabilizes factor VIII. All right. Types, 3 types. It comes in 3 flavors. The first being the most common, which is partial quantitative. So I have some, I just don't have as much as what would be considered normal. Type 2, I have it, but it sucks. It's a qualitative defect, right? And then type 3 is just, you're not having a good day. That's the most severe, none. Yeah. What makes it? Yeah, pathways, endothelial cells, and megakaryocytes, right? So the platelets themselves, megakaryocytes, so it helps to release it. 2 major functions we talked about, right? Circulating platelets and also stabilization of factor VIII. Can become symptomatic at any age. So it can be trucking along all cool in life and not an issue, and then kicks in. All right. So because von Willebrand is so closely associated with the platelets, right? This is how it presents. Mucosal bleeding. They tend to have heavy menstrual cycles if there are women with the von Willebrand factor deficiency. bleeding from the gums, bleeding after dental procedures, easy bruising. They walk by a counter and they hit themselves and then they end up with a huge bruise on their throat. Right? Because, again, the platelets don't have the von Willebrand's to bind to. Diagnostic testing. Sure, I'm worried about von Willebrand's factor. Maybe I should check my von Willebrand's factor. We'll skip ristocetin for a second. Factor VIII levels are often decreased. Why? It's not stabilized, right? Von Willebrand also stabilizes factor VIII. Yep, and then you guys know the CBC should be normal, right? Platelets are typically normal. And then your PTT, normal to prolonged. Sure. So ristocetin, again, I go back to no treatment denied. So ristocetin was an antibiotic that they used to use. Then they discovered that it's causing all this thrombocytopenia. So they figured out, hey, the ristocetin actually can affect the von Willebrand's factor. So now they have a test where you take the patient's plasma and you start to add ristocetin to it to see if it binds or not. Does it a glutenate? And that tells them, hey, yes, there is von Willebrand factor here, or no, there isn't, or it's going at a slower rate, so they can figure out like what's the percentage. And that's your ristocetin. Got it. Again, with your von Willebrand's factor, impaired platelet adhesion, typically normal to elevated PTT, right? And there it is down there, binding. All right, treatment, desmopressin. What does the desmopressin do? Tells the subendothelium put out more von Willebrands. So is this going to do you any good in a patient that's type 3? No, because they have none. They can't produce it. Right? And then von Willebrand's factor concentrate. Go on von Willebrand's factor, maybe I'll give them some von Willebrand's factor. Pretty straightforward. And because of the issues with factor VIII that comes along with von Willebrand's, do I need to throw some factor VIII concentrate in there? Right. But your management, typically, desmopressin is your go-to. And then just, hey, counseling patients, talking to patients. These patients bleed easy. Dental procedures, they bleed. Right. So just plan stuff out. Menstrual loss. Do they sometimes give them desmopressin or even the von Willebrand's factor concentrate around their menstrual cycles? Yeah. So are you going to be managing this patient? I know I don't want to be managing this patient, right? So patients like this really, somewhere in the scheme of things, somebody along the way, and it might have been you who discovered, but you sent this patient to a hematologist, right? They need to have a plan. Because simple stuff, simple everyday normal life stuff can be bad. All right. Topical TXA. Alright, so to get a little bit of a nosebleed, some epistaxis, can you put some topical TXA on there? And you see the kicking time for desmopressin, which isn't bad, 30 to 60 minutes. So in general, manageable condition with some planning and appropriate care type things, right? But you just can't go along life willy-nilly and think everything's gonna be cool. Any questions on the von Willebrand's factor? Okay. All right. Hemophilia A, hemophilia B, secondary hemostasis. Secondary, we're dealing with what? Coagulation, right? So then we're looking at factor deficiencies. X-linked, males. Again, males were screwed, right? Hemophilia A is a factor VIII deficiency. Hemophilia B, factor IX deficiency. Classical presentation. Hemarthrosis, muscle hematomas. Again, coagulation problem, this is what we're looking at, right? They typically present as such, as opposed to like the primary, which is more of a petechial problem. And there is the genetics of it. All right, because it's X-linked, This first one here, yep, father with hemophilia, mom stone cold normal, and you can kind of see how it plays out, right? The female kids become carriers. In this case, father without, mother's a carrier. Yeah, there you go. Daughter a carrier, and one son has a hemophilia. So women, doesn't seem to have been an issue. I don't know if I like that so much. I don't know about you. Be fair. All right. So again, hemophilia A, factor VIII deficiency, right? You can nerd out on the mutations if you want to. Hemarthrosis, 75% of the bleeding episodes, right? Take your pick. Big joint spaces bleeding into the joint. Right? Painful, not fun. And this can just happen spontaneously, right? Go to sleep, you wake up and your knee's swollen, right? Full of blood. You bump yourself getting out of your car and your knee is swollen, full of blood, right? And there it is, right? So over time, if that happens over time, there's a lot of destruction to the cartilage, to the joint. Not good. Right? Hemophilia B, factor IX deficiency, looks a lot like hemophilia A. Clinically indistinguishable. So a patient presenting to you with these symptoms, right? So what are you going to do to tell the difference? Labs. Exactly. You're going to order your factor assays. Right? Similar clinical appearance, like we just said. Yep, got it. The only method to differentiate them, there you go, your factor assays. All right. Factor VIII, factor IX, intrinsic or extrinsic? Intrinsic. So PTT is prolonged. What is your PTT measure? What pathway? Intrinsic. Right. And then how you go about managing it, right? Factor deficiency, hey, do I replace the factors? Prophylaxis, do I give it to them ahead of time sometimes, right? Regular transfusions to prevent. If they're bleeding a lot, sure. Maybe some desmopressin might help, especially with the factor VIII deficiency, right? So with hemophilia A. And obviously I would avoid like your aspirins and your NSAIDs and stuff that's gonna make it more likely to bleed. Any questions on hemophilia A and B? Factor VIII, factor IX deficiencies, presents as hemarthrosis. It's your typical presentation. And you can kind of see here, this just tells you, depending on how severe, right? So start with a mild, right? Factor activity still more than 5%. Bleeding, yep, some occasional, sure. 1 to 5% moderate, and you can kind of see there. And then if their factor activity is less than 1%, right? Spontaneous hemorrhage, starting early infancy, starts early on. Frequent hemarthrosis, diagnosis is usually made early. Right? So even, right, 1 to 5%, greater than 5%, not so bad. You don't need a whole lot of this stuff. All right, moving on. Coagulopathy of liver disease. All right, just intuitively, if you're having problems with your liver, what else are you potentially having problems with? Your coagulation factors, right? They're all synthesized in the liver. Right? So if my liver is taking a hit and I'm not producing this in the sufficient quantities, it could be a problem, right? All right, liver synthesizes your dysfunction pro and the anticoagulants, right? Like the antithrombotic protein Cs and so forth. Primary hemostasis may also be affected the liver, yep. And then thrombocytopenia. What does the liver produce in relation to platelets? TPO, thrombopoietin, right? So Again, if the liver takes a hit, I'm not producing the thrombopoietin, I'm not getting the proper stimulation for my platelet production. All right. So if all my factors aren't great, my platelet may be not great, all right? PT, yeah, right, elevated, not producing my extrinsic factors. Severe liver disease, PTT also starts to go up. Okay. Diagnostic. Your PT-INR, we said, is going to be elevated, fibrinogen low. You can get your liver tested to kind of see what's going on with the liver. And then the platelet count often decreased. Treat the underlying liver disease. If the liver is taking a hit and the liver is the problem set, if I can correct what's going on with the liver, then it should correct the problem. FFP, haven't talked about all the FFP and the blood products yet. But what is you guys? What does FFP have? That's all your coagulation factors. It's just plasma, right? Fresh frozen plasma. So that's all your coagulation factors. And in specific concentrates, potentially, sure, platelet transfusion for severe thrombocytopenia. But again, the idea here is if I can correct what's going on with the liver, then I should fix the problem set. And in the meantime, I may need to do some of this stuff to supplement whatever's going on. All right, DIC, my favorite. I love this disorder. You guys will too. This is one of the scarier ones to me. Right? This is the one that if you miss somehow, and you blink your eye and you're not paying attention and you don't do what you need to do, your patient can die on you. Right? All right, so DIC, coagulation. Right, so what we got here, widespread activation of coagulation, you form these microthrombi, right, and then consumption of the platelets, consumption of your clotting factors, that's why it's called consumption coagulopathy sometimes. Associated with sepsis, trauma, malignancy, obstetric complications is a big one, and an ABO incompatibility, right, so these are the things, so you get some procoagulants that gets introduced into the system. And that's really what's happening with all of this stuff here. Some procoagulants that get introduced into the system. It's kicking off your coagulation cascade. It's kicking off all your clotting. So you clot, right? What happens when you start throwing these thrombi everywhere? Tissue ischemia, right? I start to throw all these thrombi. So I get all these clots everywhere in my system. And eventually, I get all these clots in my system, right? And the body wants to break it down, but part of that is I start running out of my stuff. I've used up all my platelets. I used up all my clotting factors, right? And then you start to bleed. Because then the body sees these clots and it wants to do what? Break them down, right? So now the bleeding increases more. Right. And I can't respond because I've used up all my clotting factors, I've used up all my platelets. So clot, bleed. These people can bleed on you like crazy. Right? They'll start bleeding out of their IV lines and everywhere. This is when we'll talk about the FDP here, or this in a second. Right? So DIC, not a primary disorder, but a manifestation of something going on. Something triggered that DIC. And what are the things that can typically we think of for DIC? Sepsis, what else? OB. OB is a big one. That's why OB scares the bejesus out of me. Conditions, right? That damage to endothelium. Sepsis, sure. Trauma. Trauma is a big one, right? Even snake bites potentially. Right, so some procoagulant gets into the system and kicks this off. You gotta identify it. There it is. All right, activation, right? You get the fibrin deposition. You start to use up all your platelets. So my platelet levels go down. I'm using up all my clotting factors. So what happens to my PT and my PTT? They go up, right? D-dimer, what did we say the D-dimer was? Right, breakdown, right? So the body's responding. The body wants to break down all these clots. So now my D-dimer goes up. We'll talk about schistocytes and all that stuff. All right, diffuse bleeding, ID sites, mucosa, everywhere, they bleed. It's terrible. Thrombosis, right? They're throwing all those clots. The result of all those clots is, hey, if it's depending on where those clots are, right? It's causing some ischemic damage. And you can kind of look at this chart here and kind of figure out, sure. So I'm throwing a bunch of clots in my kidneys. Not good. Acute kidney injury, hematuria, the lungs, right? Presenting as hemoptysis. And all of this is happening like simultaneously, right? So that's the thing. All right, DIC. Again, you used up all your clotting factors, so your PT, PDT is up. You've used up your platelets, so you're showing thrombocytopenia. You've used up the fibrinogen, so your fibrinogen is low. And then your FDP becomes elevated. Consumption coagulopathy. This is the one where all your lab results look crazy. Yeah, all your labs are wrong, right? Everything is out of whack. Any questions on DIC? So this is a good one to know, right, for several reasons. All right, treat the underlying cause. So if I start attacking the problem and just try to treat the bleeding or whatever's going on, and that underlying cause is still present, I'm always going to be behind the power curve, right? So if you treat the underlying cause, just like anything else we talked about, all right? Coagulopathy of liver disease, treat the underlying cause, treat the problem. But in the meantime, you got to figure out, hey, what do I need to do to keep this patient alive while I figure out what's going on, where I can correct whatever the problem set was. Do they need platelets? Do they need FFP? High mortality without prompt treatment. So key to this is recognizing it early on and then doing some interventions. Right? In medicine, we talk about doing the right thing at the right time. This is one of those conditions where you got to do the right thing at the right time. Any questions on DIC? Consumption, this thing, consumption coagulopathy, right? I've used up everything. Primary versus secondary hemostasis. What's primary? Platelet plug. What's secondary? That fibrin, right? The coagulation cascade forming the fibrin matrix to support the platelet plug. All right. PT, PTT, know when they're high or not. And then von Willebrand's. What's the problem set in von Willebrand's? What's the function of von Willebrand's? Right. That platelet, right? So that platelet aggregation. So if I don't have von Willebrand's, then I have a problem forming my platelet plug. It also does what? Stabilize factor VIII. Each factor VIII for my coagulation cascade. If I'm low in factor VIII, then I have a problem there. Right. Hemophilia, we talked about factors which? 8 and 9. Coagulative liver disease, you guys good, and then DIC. That's the one that'll get you. Right? And that's, just think of that as consumption coagulopathy. Sure. Acute bleeding, prompt administration, yep. Sure. Chronic, preventive, surgical. Like, so like with von Willebrand's or any of these conditions, well, not any of them, because you don't worry about so much with DIC. But if it's an inherited disorder, something where they have a prone to bleeding, right, then they got to plan out these surgeries. Do they need prophylactic concentrate? Do they need prophylactic meds, something ahead of time? Sports, contact, sure. Soft bristle brushes, sure. Right, easy bleeding from the gums in some of these disorders. Any questions? That was quick and easy and painless. You're laughing. Maybe not so painless. Painless for me, not for you. Anybody starting to look at hematology yet? What's your next step? EMED. So is that where all the focus is? EMED is easy. All right, hey. Take 10 minutes, come back, and what is it? Middleton. Is there a Middleton in the